Hello, everybody. Thank you for joining our meeting. Today we have Dr. Mazen Karela once again talking to us, and he is talking to us about syndromic testing and the use of rapid diagnostic molecular testing in pneumonia and sepsis. So thank you, Dr. Karela, as always. I will also say, as we always do, that IC Reach is an open source for educational materials. So please do consider sharing about this and supporting it. And every update and all the information you need is on the website. Okay, Dr. Karela, I'll hand over to you.
Oh, thank you, Jenny. So we will be talking about syndromic testing. And I think a lot of places now started to accommodate those testing. So it would be good to go through the details of how we do those, what kind of tests we have, and how we make interpretation of results. And the outline of the talk will be first, we'll see the impact of inappropriate and delayed antibiotic therapy, just to outline the importance of making rapid diagnosis. And then we'll screen through the traditional tools in infectious disease diagnosis before we detail on some of the molecular rapid diagnostic testing. Of course, we will present the sensitivity and specificity of those tests, and then we'll see how they impacted our antibiotic use and outcomes of critically ill patients. We'll give some case studies so we can illustrate how we can make interpretation of those tests for the benefit of the patient and the ICU. But first, I would like to define the syndromic testing, just if this is a new term to you. It is the process of using one test to simultaneously target multiple pathogens with overlapping signs and symptoms. Let's give an example. A pneumonia can be caused by either bacteria, viruses, or atypical bacteria such as chlamydia, legionella. It would be very difficult to differentiate among different types of pneumonias based on the clinical syndrome. They do have overlapping signs and symptoms, and it would be difficult without doing multiple tests. This test could include sputum gram stain, sputum culture, blood culture, urine Legionella antigen, urine pneumococcal antigen, nasopharyngeal swab for rapid test. So you would require to request multiple tests in order to make the diagnosis. With syndromic testing, you would do one test that will screen all those different bacteria and viruses for you and present them very quickly so you can make appropriate diagnostic and therapeutic options. So we're going to use some terms. As you all know, ASP stands for Antibiotic Stewardship Program. MRDT is Molecular Rapid Diagnostic Test. NAAT is Nucleic Acid Amplification Test. And PCR, of course, polymerase chain reaction. So first, the impact of inappropriate and delayed antibiotic therapy. In this study, which goes back to 2006, it shows that delaying antibiotic therapy is happening a lot in the ICU. And you can see here that only 50% of patients in septic shock received antibiotics within 6 hours. We try to give those antibiotics within the first hour. And you can see there's a major delay. Each 1 hour of antibiotic delay is associated with 7.6% increase in the absolute mortality rate in the ICU. So it's very detrimental that we start antibiotics as soon as possible. And these antibiotics should be appropriate for the patient's condition. When you start ceftriaxone for Pseudomonas, it's not an appropriate antibiotic, and that means that you're delaying appropriate therapy, and that is associated with increased outcome. This is more recent study from 2023 showing you the percentage of appropriate empiric therapy. And you can see the percentage does not go higher than 65 in certain organisms, such as Acinetobacter. If we are dealing with resistant organisms, the appropriate antibiotic therapy is only 55% in carbapenem-resistant Enterobacteriaceae. In VRE is around 60%, and Candida is not more than 65%. This is associated with an increased mortality. You can see the mortality is less when you have more appropriate antibiotic therapy to the patient, which is common sense. Putting it all together, the gram-negatives, if the antibiotic therapy was appropriate, mortality rate is 12.8%. If it was not appropriate, is around 20%, almost doubled. In gram-positive cocci, 15% versus 21%, and in Candida, 24% versus 34%. So it is very important that we detect the organism very rapidly so we can cover the organism appropriately. At the same time, given antibiotics for longer time or unnecessarily is associated with increased resistance rate in the ICU. In this study that was published in 2019 in pharmacotherapy, included more than 7,000 patients with severe sepsis who received at least one anti-pseudomonal beta-lactam antibiotic. In this study, it showed that there's an increased rate of resistance to the anti-pseudomonal and beta-lactam antibiotic on average, or the median time took 17 days, and every additional day is associated with a 4% increase in developing resistance. And that's why we need more rapid tests so we can actually target antibiotic therapy in a better way. Traditionally, if we include all the laboratory tests that we have available to make the diagnosis of respiratory infections, we can talk about traditional testing that includes gram stain and sputum cultures or blood cultures. As we already mentioned, antigen testing, such as the direct antigen for SARS, influenza, or Pneumococcus legionella in the urine, for example. The gram stain cultures would take around 2-3 days to get the final results. Gram stain within a few minutes, and those antigen tests within a few minutes. You can use PCR testing, and you can use a single PCR that is targeting one organism. You can use triplex PCR, such as the test available for influenza A, B, SARS-CoV-2, and RSV. So those usually you get the results within maximum 1.5 hours. So it is very rapid in determining the organism, but here you're selecting specific ones that you need to do PCR for. More appropriately, with syndromic molecular testing, what you do is broad coverage of viral and bacterial pathogens in a multiplex PCR, a single test that covers multiple organisms. The traditional way of making diagnosis, what we call standard of care methods, this would be the gram stain cultures, any specific rapid testing. The problem with those testings that they have variable sensitivity and specificity. The turnaround time is sometimes more than 48 hours. It may take 3 to 5 days sometimes to get the final identification of the organism and the sensitivity. Of course, results can be difficult to interpret when we have resident flora, such as what we have in the sputum. And you need to identify, if you want to identify a typical bacteria or viral pathogens, you need to have specific tests for those. So this is where the molecular rapid diagnostic test would actually perform better. And we're going to just talk about those tests in pneumonia and sepsis. And a lot of those tests are available commercially. I'm sorry to include the commercial names here, but this is the only way I can differentiate between the different or among the different tests. What we're going to be talking only about the FDA cleared panels. We have two different panels, and one for pneumonia and one for upper respiratory panel. Of course, we can use the upper respiratory panel to make a diagnosis of pneumonia. A lot of organisms starts in the nasopharynx and then complicates with pneumonia. So the FDA cleared pneumonia panels include the BioFire Film Array Pneumonia Panel, and another good one, which is the Obgene Univero LRT panel. From the upper respiratory panels, we're going to be talking only about the BioFire Film Array, similar to the pneumonia panel. We'll see the organisms, but there are multiple other panels available commercially and FDA approved. The difference between the Univero and the Film Array Pneumonia panels would be the time to results. You can see how we can obtain the results within 60 minutes in the Film Array panel, which would be preferred compared to 4.5 hours in the Univero panel. We have 15 different organisms, and those are detected semi-quantitatively, and 3 atypical pneumonia viruses and 7 antimicrobial resistant markers in the Film Array Pneumonia panel. When we say semi-quantitatively, that means we can determine the number of organisms, or we can get an idea about how heavy the growth is. Qualitative cultures would give you just positive or negative. So the atypical pneumonia would be either positive or negative, viruses positive or negative, detected or not detected. The Univero panel includes almost the same bacteria. The atypical bacteria, it has the pneumococcus fungus and 10 antimicrobial resistant markers. We can do the Film Array on the sputum or on the lower respiratory secretions, such as.
The Film Array is user-friendly multiplex PCR. This innovative system simplifies molecular testing through a completely automated protocol, beginning with integrated sample preparation and ending with automated analysis of results. Starting a Film Array run is easy. All of the reagents required to test a sample are preloaded and freeze-dried into the reagent storage compartments of the Film Array pouch. To begin a Film Array run, the pouch is first placed into the loading block. Then, hydration solution is injected into the pouch through the blue inlet port on the right. The vacuum in the Film Array pouch automatically draws the correct volume, eliminating the need for precise measuring and pipetting. Next, sample is added to the Film Array sample buffer. This solution is then mixed and then injected into the Film Array pouch through the red inlet port located on the left side of the pouch. Again, the vacuum in the pouch automatically draws the required volume. The Film Array instrument is now ready to set up. The Film Array pouch is loaded into the Film Array instrument and a barcode reader is used to enter the pouch ID. The sample ID can also be scanned with the barcode reader or entered manually. Last, the user ID and password are entered and then the run is started. You are free to walk away since all remaining steps are completely automated. The Film Array displays the remaining time. Now let's take a look at what happens inside the pouch. First, The sample is moved into the lysis chamber, where the film array physically lyses any cells and viruses through a process called bead beating. Ceramic beads are agitated at high speed to break open cells and viruses and release the nucleic acids. These nucleic acids are then bound by magnetic beads, which are then moved from the lysis chamber to the purification chamber. Here, a wash buffer removes any remaining cellular and viral debris. The film array activates a magnet outside the pouch, which holds the magnetic beads in place while the debris is washed away. Next, an elution buffer releases the purified nucleic acids from the magnetic beads. The magnetic beads are again magnetically secured while the nucleic acids are moved to the first stage PCR chamber. A reverse transcription step is performed to convert any target RNA into DNA. This is followed by a high-order multiplex PCR involving dozens of primer pairs. During this first stage PCR, many reactions simultaneously occur in this single large volume reaction. The products from the first stage PCR are then diluted to limit any remaining first stage PCR primers. Next, the diluted first stage PCR products are combined with a fresh master mix and then aliquoted to each well in the array. Each well of this array is pre-spotted with one pair of second stage PCR primers. These second stage PCR primers are designed to amplify sequences contained within the products from the first stage PCR. This eliminates non-specific products associated with traditional multiplex PCR. Because the second stage primers specifically amplify only target DNA. A fluorescent double-stranded DNA binding dye is used to monitor each reaction. The second stage primers in each well are designed to detect one specific target. Organisms are identified based on which wells in the array are positive. The film array performs a melt to confirm the presence or absence of specific temperature signatures of the second stage PCR products. The film array software processes the data and makes a positive or negative call for each organism. These results are provided in one easy-to-read report. From integrated sample preparation to automated result analysis, the film array is user-friendly multiplex PCR.
So as you see, it's very simple procedure. Most of it is automated. The principle is essentially just release the nucleic acid and amplify it. We use two-step PCRs. One of them is generic and then very specific with the second step to identify certain organisms. And with this, the organisms that we identify include bacteria that is actually, as you said, is 15 different ones: Acinetobacter, Enterobacter, Escherichia coli, Haemophilus influenzae, Klebsiella aerogenes, Klebsiella oxytoca, Klebsiella pneumoniae, Moraxella cataralis, Proteus, Pseudomonas, Serratia, Staphylococcus aureus, Agalactiae, Streptococcus pneumoniae, and Streptococcus pyogenes. In terms of the atypical bacteria, and this is only qualitative, as we mentioned, positive or negative, compared to semi-quantitative for the other bacteria: Chlamydia pneumoniae, Legionella pneumophilia, and Mycoplasma pneumoniae. We have 8 different viruses that include adenovirus, coronavirus, human metapneumovirus. Very difficult to differentiate between rhinovirus and enterovirus, so you get a result for both at the same time. So it depends on the specimen that you do. Of course, most of the respiratory viruses would be rhinoviruses. Influenza A virus, influenza B virus, parainfluenza, respiratory syncytial virus. And then we have 7 different antimicrobial resistant genes, mainly the carbapenemases, IMP, KBC, NDM, OXA48, and VIM. So you can see major ones involving carbaminomases. We're going to be having our next talk about resistant organisms, and we detail in explaining these enzymes and how we can treat them. And then it can also detect ESBL, mainly the CTXM, and finally the MEC-A and C for methicillin resistance. As we already mentioned, 60 minutes to get the results. Very good sensitivity and specificity, and this data from the company. We'll see the studies that done in real life. Now, when you get the results of the 15 bacteria, you get it semi-quantitatively, as we mentioned. And the way it works is the following. This is the traditional way of doing cultures. We get the specimen, and then we wait for any growth on the different trays that we have or dishes. And it takes 24 to 48 hours. Depending on how heavy the growth is, we can give a number of plus signs, and then we give an idea to the clinician on the amount of growth that is present in that dish. Again, we don't identify selective ones. We just put them on the tray and we see what's been cultured out. The media that we have on the Petri dish should actually allow for the growth for most of the bacteria, but specific ones would be requiring special media. And this is one of the difficulties of the traditional methods, that you need to select the media where you're going to culture the specimen at. Now, with this method, what we do is different. First, we select specific organisms. As you see, we're targeting these 5 different organisms here, and we're doing PCR against those organisms. Okay, so if we have a different organism, we will not be able to detect it because we're targeting specific ones, but those are the most common ones causing pneumonias. And then when we get the results, we will see, okay, so when we get the results, we either detect it or not detect it. So you can see here that we have 2 organisms that are not detected. However, we have 3 other organisms among the 5 that we targeted. Those are detected. And we get different bins here, as you see, in terms of how much do we have, how much organism do we have in that specimen. And the results are in copies per milliliter. And what we have here is this organism is at 10 to the power of 4. Compared to these 2 other organisms, we have here 10 to the power of 6 and more than 10 to the power of 7. So if we have the specimen coming from the sputum, that means we're going to be targeting higher number of copies. So you would consider it positive if it is more than 10 to the power of 6. If we have a lower respiratory specimen, which such as the BAL, at that time 10 to the 4th, this is similar to what we do with the traditional semi-quantitative cultures. So this is how the results would be presented to you. The other company that has the lower respiratory tract panel is the Univero. As we mentioned, it takes 4.5 hours to get the results. So it's faster with the film array. Almost the same bacteria here, the same atypical bacteria. As I said, we have the Pneumocystis carinii pneumonia added to this panel. And we have expanded number of antibacterial resistant genes here compared to the film array testing. And in addition to that, if the sputum is not available to you, a patient is not able to produce sputum, at that time you can rely on the respiratory panel of the BioFire, the same company. You can get the nasopharyngeal swab and test it for different viruses and different bacteria. In terms of viruses, it's almost the same ones, expanded list. You have all the subtypes of the beta influenza. You have different subtypes of the influenza A. The coronaviruses would include the 4 major ones in addition to the COVID-19 or SARS-CoV-2. Bacteria would include Bordetella, whether it's parapertussis or the pertussis, chlamydia, pneumonia, and mycoplasma pneumonia. Of course, you're lacking the Legionella here. It is only on the lower respiratory tract panel. Again, the sensitivity and specificity is close to 99% for the specificity and 97% for the sensitivity. And I want you to understand when, if we have a test that has 100% specificity, the positive test means that there is infection. So you cannot ignore a positive test that has 100% specificity. And the third specimen that you can get for rapid diagnostic test would be the blood. So again, you get nasopharyngeal swab, you get sputum or BAL, and you run it through the multiplex PCR, and then you can choose a diagnostic test for the blood. We have different techniques for detecting the bacteria or identifying, let's just say, the bacteria in the blood. I'm not going to detail into those techniques, but you have the MALDI-TOF MS. This is mass spectrometry. Depends on the different proteins present in the organisms. And then you have the real-time PCR detecting a single organism compared to the multiplex PCR, and we're going to detail in the BioFire film array in the blood. You can do DNA microarray, specific companies for that. And then we have the T2 magnetic resonance technology. This is from T2 Biosystem company. It detects bacteria and candida, only limited number. But this is the only technique that would detect the organism in the blood before having positive blood cultures. The other ones would require that the blood culture is positive, and then this is a rapid or more a faster method to identify the organism. And the last method is the fluorescence in situ hybridization. This is from accelerated phenotype testing. The benefit of this that would give you early ID in addition to MIC specific against specific antibiotics. Now, the BioFire film array on the blood would include different gram-negative organisms. You can see the different ones included here, including Bacteroides fragilis and the Acinetobacter, Enterobacteriaceae, Haemophilus influenza, Neisseria meningitidis, Pseudomonas aeruginosa, and Stenotrophomonas. And then we have gram-positive bacteria, Fecalis, Faecium, from the Enterococci, Listeria, Staphylococcus, whether it is aureus, epidermidis, Streptococcus species, Ehrlichia, Pneumonia, and Biogenus. And then we have yeast, mainly 6 different ones from the Candida and the Cryptococcus. And then the antimicrobial resistant genes, the same carbapenemesis that we have on the pneumonia panel. We have colistin resistant gene, same ESBL and the methicillin resistance. In addition, we have the vancomycin resistant gene, the VAN-AB, that we can detect in Enterococcus. So as you see, it's a wide spectrum of organisms, and again, this test would require that you incubate the blood first. When it turns positive, at that time you can detect these organisms quicker. And of course, if that test did not detect anything, that means the bacterial culture that is positive contains another organism or a different organism that the ones you're targeting in this panel. The way you get the results on the sputum, as we mentioned, you get the copies per ml for the bacteria. So you can see 10 to 7 copies per ml Klebsiella oxytoca. This is compared to traditional cultures of colony forming units per milliliter. And you can see that the gene is targeted, and the gene that is targeted is detected or not, compared to ESBL positive or negative in the traditional cultures. Just quickly want to mention the T2 microsystem. The beauty of this system that you can run it directly on the blood, and it takes 3 to 5 hours to get the results. Very simple and very, very sensitive. You can detect as low as 1 colony forming unit of the Candida. You can detect the Candida albicans, tropicalis, parapsilosis, cruzii, glabrata. We have limited number of bacteria, but you can detect them in 2 to 11 colony forming units, Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, and E. coli. Again, those are the most common ones actually in the intensive care unit for patients developing pneumonias. And then you have the T2 resistant genes, and you can see MEC-AC, VAN-AB, the ESBL, KBC, OXA, and the metallactamases, and you have AMP-C here. So the major genes that might be responsible for resistance. You need to know that the number of cells required for blood culture positivity is typically in the range of 10,000 and more, compared to what we see here is 2 to 11 colony forming unit. Huge difference between the traditional way and this new method. So why doing the rapid diagnostic test? So first, it can help in our diagnostic stewardship, can inform or stop diagnostic testing for other pathogens. If we get the result within an hour or two, and we know that the organism is compatible with the clinical syndrome, we don't have to do any other testing. And it also inform and counsel patients on prognosis and risk of worsening. We would tell the patient if we detect, for example, COVID or SARS-CoV-2, that patient would be at risk of deterioration and progression into more severe disease compared to if you detect a rhinovirus, for example. And it also gives you information that can be helpful in the isolation precautions. So you can put the patient in isolation quicker for patients with influenza or COVID-19. This is both in the hospital and in the long-term facilities. And finally, it is very helpful in the antimicrobial stewardship. You can avoid overuse of broad-spectrum antibiotics or unnecessary antibiotics. So benefits versus drawbacks. So again, the pros of these tests that simultaneously can test for many pathogens. They can cause similar clinical syndrome, gives you results very quickly within an hour or so. They are very sensitive and specific. If used within the stewardship program, it can improve diagnostic yield and enhance clinical decision making. However, the drawbacks would be you only see what is on the panel. So this is targeted test towards specific organisms. So if what you have is different than what is on the panel, you won't be able to detect that organism. And if it is not used clinically within the stewardship program that you have within your hospital, it may not change management. And at that time, you would be concerned about the added cost to the patient if we're not changing the management for the patient. So how do these tests perform? Again, based on the data that is available at the company, and here we have the BioFire system. Sensitivity on the BL is 96%, specificity of 98%. The film array on the sputum is 96%, 97%, very similar. Higher sensitivity and specificity, close to 100% in the BioFire film array blood panel. And this, of course, would give you a very high negative predictive value and positive predictive value. So you would be able to rely on these tests to make decisions. So in real life, in ventilator-associated pneumonia, the sensitivity was around 90%, specificity still high, 97%. On the endotracheal aspirate, sensitivity was less, 71% or 2%, and specificity was 97%. The rapid test on blood cultures for ventilator-associated pneumonia has a lower sensitivity than reported by the company, 79%. This gives you a positive predictive value of 87%, and the specificity is still very high, 98.1, with a negative predictive value of 96.6, and this is on the blood. So you would be concerned whether we can detect more spectrum of organisms with this testing compared to the traditional ones. Like, not concerned, but actually you need to be aware that you're going to be detecting what's in the sputum with this test. This is on lower respiratory tract sample. You can see number of or percentage of specimens that were positive in the BL, close to 50%. In the sputum, 72%. Again, you culture out everything that is in the sputum, and the sputum goes through the upper respiratory tract. It is actually contaminated with the upper airways. Now, the other thing is that you can detect multiple organisms. So co-detection was present in almost 39% on the BL and in 56% on the sputum. But this testing helped in identifying more organisms. So it's identified at least one bacterial target in 63% more on the BL specimens compared to the standard of care cultures. You can see here this is the pneumonia panel, the PN, and the standard of care. Those are the traditional methods of cultures. So of course we need to see agreement between the standard of care and the pneumonia panel, and that is seen in 62%. They were both negative in patients with pneumonia, in 62%, or at least in specimen of patients suspected to have pneumonia. Now, they both agreed and they were positive in 23%. However, you can see in 15% of the cases, the pneumonia panel was positive. However, the standard of care cultures were negative. So it helped identifying more organisms compared to the traditional ways of culturing. So what would be the impact on antibiotic use and outcome? And of course, when you get the results, you can to make a decision. You may escalate antibiotics. You would say, well, that organism was not covered, and we can add antibiotics to the regimen. But most commonly, what you end up having is you start with broad spectrum antibiotics. Once you get the results of this testing, you can de-escalate. And you would be concerned that you inappropriately de-escalating. And however, in this study, it did not happen in more than 1.6%, which is good. So in most of the cases, we did de-escalation, and it was appropriate de-escalation in 48% of the cases. And also in small percentage of cases, we escalate the antibiotics, and it was appropriate in 4.3%. But it was inappropriately escalated in 16.6%, and there's no change in 29.2%. In general, this testing would potentially give you 6.2 fewer antibiotic days per patient. So as per this study is very helpful actually. And this is another study looked at the predicted changes if the test was used, and they predicted that they would have de-escalated in close to 66% of the cases, expanded in 10%, expanded and de-escalated in 7.8%, starting antibiotics in 3.1%, and no change in 12.4%. Now, when we get those results, it's very important that we act on those results. And in this study, this goes back to 2015, you can see how interpretation of this test and action that is done is different, whether we have stewardship program in the hospital or not. So the first row here is the traditional methods. And again, we can get the identification of the organism within 24 hours, let's just say. And at that time, we may expand. So the E stands for expansion or escalation. And the D is de-escalation. So you get the ID and you wait for the sensitivity before you de-escalate. So de-escalation occurs around 36 to 48 hours. Now, if you have rapid testing, and this is on the blood, you get identification much faster than compared to traditional methods. And you may escalate antibiotics quicker here. However, de-escalation is not happening, and this is specific to this study. De-escalation did not happen unless there's a stewardship program. And you can see here, you have the rapid test results plus stewardship program, escalated earlier, de-escalated earlier compared to traditional methods. So it's only helpful if you combine this with a stewardship program, or in other words, with actions. You need to interpret those results and make decision what to do on the patient's antibiotic regimen. And this is another study, not only showing that it's helpful in de-escalating antibiotics, it's also allowing the stewardship program to act faster. You can see here that interventions occurred within 24 hours compared to 48 hours with the traditional testings. And this is associated with a decreased cost for the patient. So this is overall cost for the in this study, it was $144,000 compared to $175,000, which is statistically significant. So using this test, despite the cost of this test, if they are used in a way that we can make adjustment on the antibiotics, it will save the hospital money. And this is actually very a good slide to see how this test can actually impact your decisions. Okay, so what you see here in this row, or in this horizontal column, what you see here is conventional cultures and antibiotic stewardship program. I'm sorry, antibiotic susceptibility testing. So the dark black is detection of the organism. And then of course, excuse me. And then of course it would take between 12 hours to 72 hours to identify the organism. And after that, it will take us another 12 hours to 48 hours sometimes to detect the susceptibility or the sensitivity to different antibiotics. So as you see here, the time may go up all the way to 120 hours with the traditional conventional methods. Now, if you compare this with the rapid testing, it doesn't matter which testing you're looking at. And since we presented the BioFire, so let's just concentrate on this. And we said that we require a positive culture in order to do the test. So it will not actually change the time to detect the organism. So detection is the same. However, we have more rapid identification of the organism. So you can see how the dark gray is shortened now from this time all the way from 12 hours to 72 hours altogether, down to 1 hour only. You can see how quickly now we're able to identify not only the organism, but also the antimicrobial resistant gene. And that will impact your antibiotic choice. However, the susceptibility testing, the sensitivity to different antibiotics is not going to change. As you see here, we just shortened the dark gray area. This is more rapid identification of the organism. If we do this with the context of antimicrobial stewardship program, the mortality is going to get better. And you can see here the gram-positive organisms. You can see mortality. This is a meta-analysis of multiple studies together with total of 2,200 patients altogether. Improved mortality with rapid testings. Gram-negative organisms, close to 1,200 patients, better mortality with using this test compared to conventional methods. In yeast, it did not matter much. Altogether, there's improved mortality. However, when they looked at whether these test results were used within antimicrobial stewardship program compared to no antimicrobial stewardship program, you can see the improved mortality was only seen when used within the antimicrobial stewardship program. And antimicrobial is not necessarily a team that you have in the hospital. It is an action you do on the results of these tests. So in general, what we do now is that when we get the test, when we get the patient with a clinical syndrome, we do diagnostic stewardship. We try to select the right test for the patient and the right time. And then we get the test results. We do antimicrobial stewardship, where we make right interpretation of the results, right antimicrobial regimen at the right time. And this way we can complete the cycle of rapid diagnosis, adequate diagnosis, and management of the patient. So let's have some case studies so we can actually see how we use those different tests to change the management. The first case is 77-year-old female, past medical history of diabetes, hypertension, presented with sore throat, shortness of breath, and generalized weakness. There was mild fever too. Chest X-ray shows bilateral infiltrates, but very minimal. And O2 saturation was 94 on room air. So next step, what we did to the patient, nasopharyngeal swab. There was no sputum for this patient. Patient was not able to produce sputum, so we could not send the lower respiratory specimen for rapid test. We sent blood cultures, and for a patient who presented with bilateral infiltrates, and it sounds like it's a viral. However, according to IDSA guidelines, you would start this patient on ceftriaxone and azithromycin. And we added oseltamivir because we thought influenza is high on the list. 1 hour later, the rapid test was positive for influenza A, and it was positive for rhinovirus at the same time. And 48 hours after that, the blood cultures came back negative. However, in fact, actually, we acted on this test here. We stopped ceftriaxone and azithromycin, and we continued with oseltamivir. Of course, one can argue that you need to wait till you rule out bacterial pneumonia. It could be bacterial infection on top of viral infection, but our clinical suspicion was very low. Patient was not producing any sputum. There is no leukocytosis with the patient. We thought that this is virus syndrome, and the rapid test helped us to confirm the diagnosis, and the patient was discharged a few days later on oseltamivir. So the test for this patient came back, as you see here, positive for influenza A virus. And as I said, you cannot differentiate by the rhinovirus from the enterovirus by using this test. So the test came back positive for both rhino and enterovirus. So in this case, it helped us to de-escalate antibiotics and make sure that the selection of antiviral medication was very appropriate. Of course, this syndrome would be the same. The same patient could have, if the patient had COVID-19, it would be the same presentation also, but the COVID test was negative. Another patient, 72-year-old female, diabetes, depression, COPD, and seizure. Patient was found unresponsive at home. Patient had DKA and evidence of left lower lobe consolidation. You can see it on the chest X-ray here. Patient was intubated, placed on mechanical ventilation. She was in septic shock, norepinephrine was used. Okay, so we did RDT on tracheal aspirate, bronchial alveolar lavage, and we did blood cultures and RDT. According to IDSA guidelines, we start patient on ceftriaxone and azithromycin. Okay, so very clear here, community-acquired pneumonia, clarithromycin, azithromycin, and ceftriaxone would be a good choice. In 6 hours, we got, by the way, we lost a specimen on the tracheal aspirate. So I don't have the results for this. However, 6 hours, we got the results on number one MRSA screen was negative. It means nothing actually, because this is committee acquired. We were not suspecting anyhow. We did not suspect MRSA. Okay. However, if you take a look on the blood, look what we found. We have MAC-AC. It means methicillin resistance, and we have Staphylococcus. It was positive. So we have a Staphylococcus that is methicillin resistance. That requires vancomycin. So we escalated to vancomycin. At the same time, we got Enterococcus, and this is again blood, Enterococcus and Enterobacteriaceae. So it's multiple organisms in the blood. Of course, it would raise the question, is this a contaminated specimen or not? Okay, anyhow, we did a CT scan of the chest, and you can see here that we have abscesses. So it's like, you know what? Let's just cover everything we see here with piperacillin tazobactam and vancomycin. So we escalated from ceftriaxone, azithromycin within 5-6 hours to piperacillin tazobactam and vancomycin. And then we got, this is the test actually. So you can see here the MAC-AC detected. And this is what I was talking about in terms of qualitative cultures, detected or not detected. And this is the blood cultures, gram-positive. It was Staphylococcus. It is not Staphylococcus aureus. It is Staphylococcus epidermidis and detected. And at the same time, we have Enterococcus fecalis that is detected. And then we have Enterobacteriaceae, and we'll see what turn out to be. So we have 3 organisms detected on this panel, no Candida. Now, when we got the blood culture, this is a final blood cultures. And the purpose of this, to show you that we only detect what we target. So we have 6 different organisms. And of course, this is a contaminated specimen. So none of these organisms mean anything to the patient. It's a contaminated specimen, but it contained E. coli, Enterococcus fecalis, Staphylococcus epidermidis. These 3 were detected by the panel because we can target these organisms. However, we do not target Aerococcus, Staphylococcus, or Providentia. And that's why we did not detect those organisms. So again, the idea of this case is we only detect what we target if it is present. The third case, 64-year-old with severe COPD, was admitted to the ICU with COPD exacerbation and required to be on the ventilator. 4 days later, patient developed fever, leukocytosis, increased oxygen requirement, and right lower lobe infiltrate. So apparently the patient developed ventilator-associated pneumonia. So what we did is RDT on tracheal aspirate, bronchoalveolar lavage also, blood cultures, and broad-spectrum antibiotic, piperacillin tazobactam, and vancomycin. This is not our usual choice for ventilator-associated pneumonia. We prefer to use cefepime and vancomycin, excuse me, and just for the risk of increased nephrotoxicity with a combination of piperacillin tazobactam and vancomycin, especially if you use it for more than 3 days. Now we got the results 6 hours later. Okay. We have MRSA screen that is negative, and that means that we do not need the vancomycin here, but let's just see the RDT results. It showed Klebsiella oxytoca, and we have a gene, a resistant gene that is positive, which is KPC. And this is actually going to impact majorly on your choice of antibiotics. And look at this, within 6 hours, we were able to determine that the pip/tazobactam is not an appropriate agent for this patient. And what's appropriate for this patient is to target the KBC, and the only way we can do it, not the only way, but one of the ways, ceftazidime avibactam. And that's what we did for this patient. Blood cultures confirmed Klebsiella, and it was actually KBC producer. And this is what you see on the panel. It was Klebsiella oxytoca, and we had 10 to 6 copies detected, and this is on the BAL. And the antimicrobial resistant gene that was positive was KBC here. As you see, this is carbamidase. The last case that I have is 44-year-old, history of hepatitis C, HIV, and mitral bioprosthesis, who has been incarcerated, came to ER with septic shock, acute kidney injury, respiratory failure, required to be intubated, placed on vasopressors, also CRRT. You can see the purpura fulminans bilaterally on the feet. Later on, we diagnosed endocarditis, and that was confirmed by echo and blood cultures. But let's just go back. Before we made the diagnosis of endocarditis, what we did is sputum gram stain and cultures. We had blood cultures and rapid test, and the patient was started initially on broad spectrum antibiotic with vancomycin and cefepime. Okay. Again, this patient is at risk. He's incarcerated, HIV positive, hepatitis C positive. Now, in 5 hours, we got nasal MRSA screen is negative. And if we're suspecting endocarditis, we should not act on this. We act on this only if we're suspecting pneumonia. But the rapid test on the blood turned out to be positive for Staphylococcus, and we had a negative MAC-AC. So it is not methicillin resistance. In other words, we can de-escalate the vancomycin into cefazolin. And since nothing else was cultured, and this is compatible with the clinical syndrome of the patient, and in fact, we knew that the patient has vegetations with the echo that was done within the hour. So we were comfortable actually to de-escalate to cefazolin. Look how quickly we were able to make a diagnosis, a very accurate diagnosis, and put the patient on appropriate antibiotics for MSSA endocarditis. And this is the test result that we got on the patient. You can see here how the Staphylococcus was detected, and it is Staphylococcus aureus, and the MAC-AC was negative. And this is the final cultures on the patient. This is Staphylococcus. It was actually persistent cultures, Staphylococcus aureus. And as you see here, it was oxacillin sensitive, meaning that the organism is MSSA. So with this, if you put things together, actually, the standard culture testings would take days to weeks before you'll be able to make a diagnosis. With more rapid testing, whether you use the antigen test or the multiplex PCR, you can get results within the hours to be able to make adjustments in the antibiotic regimen of the patient. Takeaway messages, knowing the pathogen and the antimicrobial resistance is essential in septic patients, of course, and you can target those pathogens in better antibiotic regimen. So faster identification of the organism using the rapid multiplex panels provide greater opportunity to decrease mortality and morbidity to your patients. This is only if you use this within antimicrobial stewardship. That is very essential component of rational data-driven and antibiotic selection. So I want to emphasize again that this rapid test must be combined with stewardship program for maximum impact on the outcome of your patient. So Thank you very much. Jenny?
Thank you very much, Dr. Carla. So as always, we'll just take some questions. You can unmute and ask Dr. Carla yourself, or you can put these in the chat box if you have anything you want to ask.
And they would be waiting for some studies to show that this will impact outcome and it will save hospitals money. And as I showed that clearly, we have studies and we have a meta-analysis that if these tests were used within the stewardship program, we're improving outcome to our patients, which is the goal for our healthcare delivery. And we will not associate this with increased cost. In our hospital at Sanford Health, and this is not in Illinois, by the way, I live in Illinois, but I work in North Dakota. And we have the film array available. And this is on the blood. The rapid test on the sputum is sent out to one of the local labs in town. So it takes a little bit longer than 1 hour. We get it within 5 to 6 hours. We're trying to get that machine into our hospital. I would actually make a good case to the administration in any single hospital that this test not only improve outcome to our patients, but it is associated with decreased cost to the hospital. I know that a lot of hospitals are not, especially the smaller size hospitals, do not have this methodology yet, but I think we're progressing towards obtaining this at a larger scale.
It will be an amazing tool for antibiotic stewardship and reduce hospital cost. And I agree. I'm looking forward to have it here and start using it. Right. It will be a real breakthrough.
Right. It is available. I know that is available in Saudi Arabia. A lot of our audience from Saudi here, and in fact, Dr. Ashwaq and Dr. Ahmed just confirmed that those tests are actually available there.
Okay.
I confirm. Thank you very much, Mazen. It's Hassan here. Again, another amazing lecture as usual, Mazen. I've attended a webinar during the COVID or shortly after the first wave of COVID. And one of our colleagues from the Royal Berkshire Hospital in west of London, he's got that machine. And he was telling us how amazingly he used his antibiotics during the COVID. You remember everyone was hitting in the dark.
Correct.
We were giving antibiotics right and left during COVID. And he was telling us how the usage of antibiotics was very judicious and really tailored to each patient. So I think it's an amazing tool, and I wish I have it in our hospital. We'll try to push for it, inshallah, in the due course, especially when you are dealing with immunocompromised patients. I think the value is immense, really.
Certainly, Hassan. Thank you very much, actually, for your comment. And I just want to link this actually with what Dr. Mahdali Ashwaq said in her comment here for using the T2 biosystem testing in patients with immunocompromisation. And again, this would be the ideal subset of patients where this test can actually detect the organisms, not only the 5 bacteria, but also the Candida species, the different Candida species. And the transplanted patient would be the target for this test. So if you want to maximize the benefit of those patients, you probably need to do the test on group of patients that have the higher yield out of this test, which is the transplanted patient group.
Dr. Mazen, can I ask a question?
Yeah, go ahead, Doctor. It's open discussion if you want. Jenny doesn't mind, actually, if you just unmute yourself and talk. Is that correct, Jenny?
Yes, it's good to have everyone involved in the discussion, so go ahead.
I could not attend the entire lecture, so I was able to join the last 15 minutes. But I'm looking, to listen to the recording. But since we're live and we can chat about this, the role of procalcitonin in conjunction with these kind of testing, was that ever looked at, and to see if that can validate these tests more when when you use the procal?
Well, I think doing a biomarker is another tool that is available to us to see whether we're dealing with bacterial versus viral infection. Procalcitonin, again, there's another lecture that is available. It's recorded too. It's available on the site under Sepsis. And it's in both, one in Arabic language and one in English language, that I actually looked at all the studies in the different biomarkers. No, I looked at procalcitonin alone and looked at the how we can use this test in the best way. I think the main application of the procalcitonin at this point is duration of antibiotics. I think, especially in the ICU, using procalcitonin to start antibiotic is not very validated. However, determining the duration of antibiotics, meaning that we stop antibiotics once we get to a level less than 0.5 or 80% from the peak, it is associated with the same outcome, which is that's what we want. Is like you don't want to increase the risk for mortality for those patients by stopping antibiotics. And procalcitonin did not show that's associated with increased mortality if you stop antibiotics based on its results. So I would say it would help in determination of the duration of antibiotics rather than determining whether we should use antibiotics or not. Now, in the outpatient settings is probably different. I think there's a value of the procalcitonin in determining whether we should start antibiotic or not. I would say that if we have those testing, I would give priority to these testings over procalcitonin. There are multiple factors that can actually increase procalcitonin for you, which might deter you from doing the right things for the patient.
Thank you, Dr. Khairallah.
And Dr. Shakaki, this lecture is available now in Arabic language under the education tab, but I will need to upload this version later on. As you probably noticed that we have we had period where I lost connection, so I need to work on that. It will take a couple of days.
Okay, any final questions? We'll take those now.